I am looking for that mute button, so it's preparing.
It's on the bottom left-hand corner of the actual screen on YouTube.
Okay, so I'm looking for that. Okay, I'm looking. So it's preparing.
It's on the bottom left-hand corner of the actual screen on YouTube.
Okay, that is muted, and there it is.
Okay, so you're all set.
Now I can minimize this or close it. I can close it out or not.
Never close it out.
So just stay on for the
Just
duration.
put it in the background. Yeah.
Yep, did that. Okay. All done. Take it away.
Okay, good evening to our April Health and Human Services Committee meeting. We're going to begin with a short presentation from Roberta Seymour on budget priorities in our DNS, which are being given to every committee, but we should keep in mind all the time, but especially thinking of what we can recommend in terms of budget priorities related to mental health, which is our forum that'll follow. So I'd like to ask Roberta to enlighten us. Thank you.
Thank you so much, Shelley. So this year we got a late start with our budget and priorities and our district needs. And we've also shortened the timeline. So I'm going to start with the timeline and process. So we're asking that each committee begin in April. And we're asking you this month to start thinking about all of the stakeholders that you need to be meeting with over the next couple of months. We're asking you to start meeting, whether it's in the committee or if you assign different committee members to meet with the stakeholders. So do the meetings in May and June. And in late June, early July, you need to start working on your district needs statement and your budget priorities, which you will vote on at your July meeting. Over the summer, the Budget and Priorities Committee will work on the district needs statement and putting together the priorities for the budget, both capital and expense. And in September, there will be a public hearing. And then prior to steering, and then at steering, we will vote to prioritize the budget. And then at the full board, we'll vote on, in October, we'll vote on the budget. There will not be any exceptions to this timeline. It's written in stone or concrete. So this year, we're giving you criteria for selecting priorities. And I'm going to I've sent a copy to the chairs of the committee, but in the next couple of days, I will send copies to everybody on every committee by committee. We're also asking that you submit a list to us of who your stakeholders were, who you spoke with, agencies, organizations, individuals, and contact information. We are going to start creating a database. So you'll have more, you'll be able to have information more easily available to you next year. So the criteria for selecting parties include district needs based on census and city data sources, constituent input to be gathered by committee, cost benefits relative to other programs and projects, likelihood of the item being funded without CB7 advocacy, close linkage to a policy area that is high priority for the CB7. And each committee will be asked for the criteria that they used. We're limiting the budget priorities this year to 20. That's for all committees. That includes all committees, both for capital and expense. If there are priorities that fall out of this 20, we will then send a letter to the appropriate agency saying that our top priorities were whatever, and that also included the additional priorities. So for example, if your two top priorities didn't make it to the top 20 list, if only your two made it to the top 20 list, but you had three others, they would be sent in a letter, so it would not be in vain. Any questions?
And we have our budget priorities from last year and district needs statement as a source to begin thinking about it. And we'll be working on this each month.
But yet you also want to consider that last year there wasn't a pandemic, and this year we suffered through a pandemic. So, you know, you may want to look at things with a slightly different looking glass.
Excellent point. Thank you. Okay. Thank you, Roberta, and we look forward to working with you over the months. I just saw Catherine. Hi. Okay, Catherine would like to speak, and then we're going to one quick announcement, and then we'll get to our mental health forum. So where is she? There you are. But you're muted, Catherine.
Hi, everybody. So my name is Catherine DeLazaro. I'm the co-chair of HHS along with Shelley Fine. Shelley has planned an incredible meeting. We're so fortunate to have this time to be together to talk about such important issues. It's going to be a great agenda tonight. I want to share a quick reminder about guidelines for the meeting. When we come together as a community, it's important that every one of us contributes to this being safe, inclusive, and supportive environment for everyone. I want to thank Susan Schwartz, who has been so pivotal in helping us establish guidelines for that kind of climate. She is the chair of the bylaws committee, and she has clarified that the bylaws do call for everyone to treat others with respect and courtesy. She also recently drafted guidelines for Zoom meetings. So we're drawing on that in ways that we approach the meeting. In that spirit of inclusivity and respect, let's please communicate in ways that are respectful, collegial, and professional tonight, and as much as possible in ways that assume goodwill. And please focus comments on addressing issues or asking questions. Make sure it's related to the topic at hand. And if community board members could please plan to speak only once to leave time for others to speak, especially members of the public. There will be a sign-up sheet for members of the public that we're going to pass around, that we're going to post the link to the sign-up sheet for members of the public. We're so glad you're here, and we can't wait to hear from you. So we'll post that in the chat in a little bit. And all committee members will be called on once to speak in order after we have our speakers. So I want to take this time now for something very special, which is to take this time to honor my dear friend and my wonderful colleague and my co-chair of HHS, Sheldon J. Fine, who recently received a national award for his service. The President's Volunteer Service Award is in recognition of Sheldon Fine's 175 hours of volunteer service in deployments by New York City Emergency Management during 2020. These deployments provided support for people in our community during the COVID-19 pandemic. I think that this award and its recognition of Shelley gives us an opportunity to recognize all of his service and also reflect on what we can learn from his example. In addition to Shelley's work with the Community Emergency Response Team, which is recognized by the Presidential Award, he also serves as president of the West Side Federation for Senior and Supportive Housing. Wishfish provides safe, affordable, and supportive housing in our community. He serves as commissioner on New York City Age Friendly Commission, which fights ageism and advocates for the elderly in our community. At the beginning of the pandemic, Shelley organized a team of 19 volunteers in a grab-and-go meal delivery program serving 136 households of mostly elderly homebound people in our community. He also worked with Gail Brewers and Mark Levine's staff to sign up over 200 elderly people who are elderly, to receive cooked meals from the city. He personally signed up 60 people for vaccine appointments in our community, and he helped advocate for a vaccine site at Douglas Housing. Shelley also attends the needs of people who live on the street and are at risk of homelessness to provide nutrition, clothing, and shelter. He does this first and foremost through building relationships and by meeting and working to understand people right where they are, learning from them what they need to be comfortable and responding to it, whether it's advocating for someone to have access to housing or helping someone with the process of getting a green card or buying someone an Eddie Bauer coat because that's the one he wears himself, or buying someone a hotel room because there's a blizzard and there's no other option, or shoveling someone's spot on the street so that they're comfortable, or calling me to say, Catherine, can you run over to Euclid Hall to find this person for me who has an appointment tomorrow and who I can't reach? As one community member told me, at in-person meetings or events, you'll often see people hug or otherwise express emotion in thanking Shelley for his aid or support. I too have had the experience many times of walking down the street with Shelley and having people run to kiss or hug him because they're just so happy to see him. Shelley and I have worked closely together for coming on a decade, and we've collaborated productively on many projects, but he has played as significant a role in my life outside of Community Board 7. He has lectured in my courses. I'm a professor, I have taught college courses. He's lectured in my courses at Yeshiva University and Teachers College, and he has supported and mentored my students over the years. After one visit to Yeshiva University one year, my 40 students wrote him thank you letters, and he wrote individualized and deeply reflective responses to every single one. His letters were often much longer than the letters the students wrote to him. Shelley has supported me and even my family, especially in hard and painful moments, by being very present with me and offering prayers and guidance and sharing his light and optimism. And something that we do for each other and value is that we make time for each other to talk and listen deeply. I know that he commits this time to many people. Shelley is also a lifelong educator, and he was chair of the Community District 3 School Board. And in that role, he was a strong and successful advocate for integration. For 38 years, Shelley served as either president or chair of the board of his synagogue, Young Israel of the West Side, and often leads the services and makes other contributions, such as facilitating the historic restoration of the main sanctuary. The synagogue is Shelley's second home, and on the front of the synagogue, there's an inscription that says, "My house shall be a house of prayer for all peoples." Shelley advocated for the synagogue's facilities to be open to the community so that the space can be a place where everyone is welcome. From almost a decade of conversation with Shelley, I have learned how central chesed, or kindness and compassion, is to Shelley's life and work and his commitment to taking care of everyone in our community. He believes that compassion means to feel with the feelings of others, to be in sync with the feeling of another's experience and pain in order to find ways to relieve it. He believes our words and actions should uphold the dignity and show respect for every human being. Since we are each children of God and made in God's image, we have to aspire to show the kindness that we hope God would bestow on us, that God would bestow on us. The kindness is not contingent or limited because of any judgment about the person based on what's on the surface, such as a title or a view or an ideology. That's all just surface to Shelley. The kindness is not contingent on a person's circumstances, which we can never fully know. Everyone is a human being, just like you and me. And true chesed requires more than routine acts of kindness, but also deep attention and reflection on the needs of others. Shelley often ends conversations and emails by saying, "Onward and upward," and has faith that if you move in the right direction, you'll get there with support. The goal is for our actions to show care for and uplift everyone, And the ideal place to arrive is a place where everyone can come together in community as their most authentic selves. In this moment of recognition of Shelley's President's Volunteer Service Award, we have this opportunity to reflect on what we can learn from Shelley's example, to make time, include and listen to everyone, and most important, be kind. So congratulations to Shelley for his award. And I know that I know at least Ethel wants to share a few words, and others may as well. So if we can call on Ethel first, and then Rosa, if there's other people that have their hands raised that would also like to share a few words.
Well, it's Catherine, your eloquence and your feeling and your summary of Shelley is the best, and I think we all share. So it's very much, I feel it as you were speaking, and I only want to say a very few words, and maybe in a lighter vein, because that's often the connection that I have with Shelley. I've known him as a religious and learned man, and I know that for so many years, his rabbi lived in my building and below me, and we have shared, and I have learned a great deal about Shelley's efforts to save the synagogue. There was supposed to be development deals and so on, but Shelley worked to preserve the beauty of the synagogue and to continue to save it as a community of all ages in the city. But I want to just say a very few words about Shelley and the community board, because of course that's how I know him best, and his true devotion to the community board and to the activity and the idea of the community board, and even the irrationality and the diversity and the nuttiness and the difficulties are all valued by Shelley, and he has sharp insights into people, into issues. He can sometimes be not quite sarcastic. I'll use the word sharp again. But he always, even as he is a little bit critical, it is always from a basis of respect and decency and kindness. I dare not say this about a truly religious and good man, and especially a Jewish man. He's not a saint, he's not that way, but he is a person who is of great acceptance. And I will only say one or two things about on the community board, and then stop for others to speak. Years ago, when Shelley was chair of the board, he out of the blue came to me and said, look, there's all these problems. Look, these two buildings are being built on 100th Street. The community is up in arms. We have to do something about it. I had been active before, but I wasn't necessarily ever thinking about it. Okay, well, there's another problem. And he said to me, you have to be the chair of this. I'm assigning you, and there has to be a task force, and you have to handle it. I had no idea what was involved, but I can tell you just one or two things. The first meeting that I think he told me to chair was held in Anshe Hesed Synagogue, which housed about 400 people, and I was the lone chair, many of them screaming, hollering, organizing. It was the most taxing, most extraordinary time, but I had to do it because Shelley told me what I had to do. And it was after that the two of us and the whole community worked remarkably for 18 months or 2 years to do something that nobody thought was possible. It sure wasn't perfect, the result, but it was a remarkable time, and I really learned. I owe a great deal to Shelley, and I just absolutely loved working with him. And then just other things, just one or two on a personal level, in addition to being my friend in difficult times. In this last year, I had an accident in the house when I myself was in my poor way trying to honor a particular Jewish holiday. And there was an accident that could have set me and the apartment on fire. But okay, that didn't happen. And then the next day, when I was talking to Shelley on the phone about some obscure community board thing, I mentioned this to him and kidded about it. That day, or perhaps the next, there was no notice from him, but a bag of treats and food, the correct food that had been purchased at Kosher Mart for me to have an entire dinner, and that was left by Shelley and Fran, his wife. And it was quite a remarkable, wonderful, funny, and absolutely, I was grateful. So there is much more. He is the best of colleagues on the board, and everything that Catherine said about he has time for all of his giving. And he tells me about it, and we talk about it, and I have learned a great deal, and I value him as a friend and a colleague, and always will.
So are there, I can see that there's others that have their hand raised. If Rosa, if you want to call on people.
I think Richard was first.
Oh, you have to unmute, Richard.
If we could limit it a little bit for this mental health of everybody, the presenters.
One of the, I admire Shelley so much that I put up with his sense of humor. And I've been doing that for the last several decades, his puns and his humor. And I can't imagine a community board without Shelley. He is what epitomizes what people on the Upper West Side should and do strive to be and always fall short. What amazes me about Shelley in part is some people are leaders and they tell other people what to do and they run things and they're organized. Some people hands-on and they go around and deal with the homeless population one-on-one or an apartment that needs repair. But Shelley is one of the few people I know who is both a leader and a worker. And it takes a special kind of humility to do that. So, and I'm not going to go on because I've been told not to, but it's been, to me, an honor to know you all these years. And I look forward to several more years until we're all superannuated.
Robert's next.
Also on a deeper note, I would give Shelley the award for deepness. And I've always admired his alacrity with numbers. Without reciting, without reading anything, his ability to put numbers together. But I think I recall that he was a math teacher, but I've known math teachers who didn't have that same alacrity. And of course, we all admire his parliamentarianism. Where would we be without it? It's good that Richard has something to say because he's the successor on that note, at least. But also on the same note of deepness, because it reveals something. This unrelenting punsterist that whatever your mood is, Shelley will give it a boost with these puns on, and you're just sharing a simple conversation. He'll pick up a word and go with it. So there's a lot to be admired on these deep levels, in addition to the other regular national awards and recognitions. So as we say in El Barrio, Shelley, te felicito. Y pa'lante. Was that 2 minutes?
Gracias.
Mark,
Thanks. So when I joined the community board, the district manager invited the new folks to bring baked goods. And Shelley comes up to me and says, "So you take the cake." It was my first introduction to Shelley, although actually Shelley was instrumental in getting a playground renovated over a summer when I was a PTA president at that school. And if that doesn't sound like much, except that there's the same playgrounds being redeveloped now. And I think we're about 18 months into a 9-month project. So leadership has many forms. But the thing I want to stress and emphasize is what Shelley has taught me, and which I strive to emulate without success, is that how one is of service is as important as being of service. And to get the right answer for somebody, but not to be generous with time, is really no service at all. And so Shelley's, the affection that people show Shelley, which is completely well-founded, is not just because he got a good answer for them, but because he made them feel like people. It's about people for Shelley, not just about connections and getting the job done. And so that is that's anyway, excuse me. That's as important as anything else that we can take away, and what I strive to learn from Shelley. So thank you.
Without further ado, okay, one good announcement. Most people know that we have a site in the Amsterdam edition on Amsterdam 686 Amsterdam. For Thursday, Friday, Saturday, and Sunday that just passed, another 4 days to come, and then 4 days the week after, and maybe more. But what most people don't know is thanks to a number of people, Community Board 7's advocacy, the senior task force, and Madeline, of course, and Carmen Quinones, the Tenant Association president. The governor is opening the site at 8:30 Columbus for all day Sunday from 9 to 5. So that'll be a state site. So anyone you know, anyone who needs a shot, that's the place another place to go. So the advocacy has come to some good results, and the board was in the forefront from the beginning. So that's really good. So we'll be able to skip that afterwards. So tonight, our focus is on the community mental health issues, and with that, the effects of the pandemic on mental health. And we have an outstanding, probably 3 presentations of the most outstanding service providers and contributors in the mental health and behavioral field, and we have them in our community. We're going to begin with Mount Sinai. Okay, we are blessed because we're surrounded by Mount Sinai on all sides, on 3 sides at least. And particularly we have Dr. Pramit Singh, who's Associate Professor of Psychiatry and Chair of the Department at Mount Sinai Morningside and Mount Sinai West, and our voted support at all times in our community, Brett Korn, Director of Community Affairs in the whole Mount Sinai system. So we're very fortunate, and I'd like them to begin. And I think that the importance of mental health It can't be underestimated. There are tremendous percentages that would surprise everybody of mental health issues on a normal day. We've just been through a very not normal year. So with those short words, Dr. Singh and Brad, please.
I'm just going to say a quick word. I'm
Sure.
really here to listen and to follow up if there's any need. We have Dr. Singh with us, who is always very giving of his time and is very good in his field. So with no further ado, Dr. Singh, I'm going to let you take it from here.
Great.
Thanks, Shelley, and thanks, Brad. Hi, everyone. I'm Prameet Singh. I oversee psychiatry. I'm the chair of psychiatry for Mount Sinai Morningside, formerly St. Luke's, and Mount Sinai West, formerly Roosevelt. So it's one department, and as all departments, it spans both hospitals. Even though they're two separately named hospitals, now all departments actually operate as one. I'm going to share my screen for those of you who have the ability. I have 8 or 9 slides. I will try to keep it brief, and I'd much rather answer questions that you have. Shelley had actually emailed me some possible questions, and I've tried to incorporate as many of those as I can in my talk. So if I don't, please do feel free to ask me once we're done.
Great.
Okay. So I'm really speaking for the Morningside and West campus. I do actually oversee psychiatry for the entire system, but I'm going to restrict my talk to really talking about essentially Morningside and West, which I know is most pertinent to CB7. So where do our patients come from? Well, they come from all over. About a good 40% of them come from this catchment area that is West Harlem, Morningside Heights, the rest of the Upper West Side, which is basically CB7, as you know better than me. We have Midtown and Hell's Kitchen. There's about 20% of our patients that come from other boroughs as far away as Brooklyn. They're coming from parts of Queens. Occasionally, we have a few people from Long Island. That's rare. It's probably less than 2 or 3%, but there are a few people who make their way here. I think one of the things that is true about the Morningside and West campus is that many people have treated it sort of as their community hospital. And so if they're coming there for medical care, they like to bring all their care there. So I think that's why we see this wide swath of areas that feeds into these two hospitals. As far as the types of services offered, I thought it might be helpful to give you a quick overview of what's available at these two campuses. So essentially, we have virtually almost every range of kind or level of service that you can think of. We have 2 adult inpatient psychiatry units. They're both fairly identical in size and population and the patients they serve. One of them is at Morningside and the other one is at Mount Sinai West. We also have an inpatient unit for adults that serves to help people with addictions. So it's a combined detox and rehab. It's located at the 59th Street or the Morningside West campus. It's temporarily been closed. Actually, I'm going to pause there for a second. Just to give you a quick update is, as a result of the COVID pandemic, we were in great need of nurses. There's been a shortage of nurses across the country. And unlike March and April of 2020, when we had traveler nurses that were available to us because New York City was really hit more than other parts of the country, by the time we got to the second wave, as we've now come to call it, in basically from Thanksgiving up until several weeks ago, the nursing shortage was nationwide. And so many nurses that worked in the psychiatry units, in the physical rehab units, in other, quote, non-essential, so I shouldn't really call them that, non-acute services were pulled in to cover medical units because we needed to expand our capacity for medical units. So that was that was the only reason for the temporary closure of the inpatient units. The inpatient adult unit at Morningside, I'm glad to say, opened this Monday. So just a day ago. The addictions unit at Mount Sinai West remains closed. We hope that we will start to open it probably around Memorial Day. I would ask that you not hold me to that date. And because we have other places in the system that we can accommodate these patients, we've been able to kind of get by. We also have a child and adolescent unit that's located at the Morningside campus. It's a single unit of 17 kids. Takes anyone from above the age of 5 up till the age of under 18. It's one of the few remaining units in the city, so it's greatly oversubscribed. So we receive transfers from the Bronx, from Long Island, from Upper Westchester when necessary. There are only, I think, 3 inpatient units left in the city: Bellevue, Metropolitan Hospital on the east side, and us on the west side. So that's a really valuable, I should say, unit to the community because it serves kids in need. So that's inpatient. Outpatient psychiatry, we have a pretty large general adult clinic at the Morningside campus on 114th Street. There's an assessment center that feeds into that clinic and into the other clinics. So if someone is seeking services, they come to the assessment center and are then sort of connected with services at the most appropriate of the clinics that we have. We have 2 specialty clinics for psychiatric disorders and addictions disorders. We have a very well-known, I would say, certainly a regional reputation, if not national, for personality disorders. That's at 59th Street. It is one of the very few clinics across that the Office of Mental Health holds in very high esteem and sort of holds up as a model. We also have a specialty clinic for addictions treatment, outpatient addictions treatment. That's at Mount Sinai West. Unlike the inpatient unit, they have continued to function. And I'll talk a little bit more about utilization as we go along. And then we have an opioid treatment clinic that's formerly known as a methadone clinic, but now really better referred to as an opioid treatment clinic because the treatment isn't just methadone, it's buprenorphine and other things as well. So that's the outpatient realm. Then we have significant child and adolescent services. Some of you may know, some of you may not, that we run in conjunction with the Board of Education a high school at the Morningside campus. It serves adolescents or high schoolers who either have a severe psychiatric illness or addictions or both sometimes and are unable to make it in the regular school system. And they then get referred to the CARES program, as it's known, at the Morningside campus on 114th Street. We have a general child and family clinic that provides the whole range of services to kids of all ages. That includes a parent-infant clinic, which begins to treat mothers, expectant mothers who may have difficult pregnancies or who may anticipate having trouble with attachment to their kids as they're born. And we continue to treat them as what's called dyads. So mother and child are treated together. And that's also a fairly oversubscribed clinic. We have a significant demand for it. And then lastly, we have a community services program for children that is colloquially known as the waiver program. It really is a program that's licensed by the Office of Mental Health that provides community support services for children in order to help them stay with their families and not end up in the foster care system or the inpatient units. So they provide guidance in schools, family therapy, parenting skills, and a whole range of other services that are done in the home and in the community exclusively. So those folks don't come into our campus at all. And they serve not just the Upper West Side or MCB7, but they serve really patients that are as far away as Staten Island and also parts of the Bronx, primarily, and Manhattan, of course. I'll skip over consult liaison services. There are 2 services here that I think may be of greater relevance or value to CB7 or to any community board for that matter. And that's what we call the mobile crisis teams. So the mobile crisis team consists of social workers and a part-time physician who basically are available from about 8 a.m. to 8 p.m., so about 12 hours every day, 7 days a week, Monday through Sunday. And they are sort of tasked with going out to the community to see people that may be in need of assistance. The way to get in touch with them is, and anyone can call, any member in the community, and that's where most of the calls come from. They go to a central number that New York City runs called NYC Well, or 1-800-NYC Well. And NYC Well then sends the call to the mobile crisis team in the area of the patient's address. And teams of two, usually a social worker and a social work assistant, will go out to the patient's home. They respond in about 2 hours. That's a new initiative that rolled out in the last year or two. And we'll see the person in their home if they will allow them in, evaluate them, connect them with services if that's what they need, bring them to the emergency room if that's what they need, provide them with an appointment down the road with their established provider or with a new provider. So it's really something that I think our community can utilize and probably does. Let me move along. Just a quick slide about the demographics of who we see. So you can see it's a pretty wide smattering. This is our outpatient clinic. These demographics refer exclusively to outpatient services. I don't have demographics for inpatient, but I think these are more important. So we see roughly half the people we see are women, about 30% or about a third identify as male. And then we have a smattering of folks who did not respond to our most recent characteristic survey. Race and ethnicity, as you can see, it's pretty diverse. Significant Latino population, Black, African American, about 20%, Caucasian, and then about the remaining of the 10% is a mixture of various ethnicities and groups. I mean, I think it represents perhaps the areas that we serve. The types of treatment essentially is individual therapy. As you can see, it's about 75% of our patients receive individual therapy. Roughly 40% of them are also in medication therapy, and then there's group therapy and family therapy. The length of the program, you can see that about 3/4 of our patients have been treated for over a year. That is because many of our folks, typically hospital clinics tend to treat sicker patients as opposed to community mental health centers. And therefore we have people that have more chronicity of diseases, more severe forms of their illnesses. And so they tend to stay with us longer. So here are answers to some of the questions that actually Shelley sent over. I've tried to incorporate some answers here. And again, I will not go on very much longer, but you can then ask me as much as questions that you may have about this. So what have we seen about the effects of loss and isolation on the community? So one of the questions was, what's the experience with people that have lost a family member to COVID? Few people actually seek mental health care for this. And I believe that that's fine, because grieving and loss is not a mental illness. It's a normal human experience that we all go through in our lives. And I think normalizing it, providing support and help with grieving is really what we can provide. When we do encounter that, we often will prefer not to treat these folks in the mental health clinic, but in fact, to avoid pathologizing, we'll rather have them see the chaplain service, which is very active at both hospitals. And they're available to both inpatients, and we will call them into outpatient if necessary. So that's really been the experience with people that have had losses. The folks that we have seen that have had losses are often people who have had pre-existing conditions that have either worsened as a result of the isolation or the loss, or have been sort of exacerbated. Quickly, a little bit about the experience of those who are living with extended isolation. Again, the folks we've seen have typically been people seeking care for a pre-existing illness that they've already had. So whether it's depression or anxiety or bipolar disorder or whatever else, the isolation has made things somewhat worse for them. I'm actually glad to say that the utilization of mental health services has actually gone up, and our show rates, as we refer to them, or the percentage of people that keep their appointments, has significantly improved over the course of the last year. And I can attribute that to primarily telepsychiatry, which I think is here to stay. So we're seeing many more patients through the telepsychiatry forum through our secure platform that is connected to the electronic health record. We've so quickly to those who lived through extended isolation, I think the folks who did well were people who had a sense of purpose, who may have fortunately been able to keep a job that they had responsibilities for or had responsibilities to children. And studies about stress and resilience teach us that when people have a purpose, that they are much more resilient or likely to not suffer the effects of an acute trauma. Effects of families sequestered together, both good and bad. So I think we've certainly seen mutual support. Unfortunately, I think, and this is a nationwide phenomenon, certainly there are numbers that the city has reported about the increase in, unfortunately, domestic violence, sometimes a result of, sometimes not a result of increased alcohol consumption at home or other drugs. People's living size has had a significant impact, as you can well imagine. And I think those are sort of some of the, just very quickly speaking about the effects here of loss and isolation. So the effects on those with chronic conditions, I think there were several things that we noticed over time, which are, many of these have been now published from parts of the country as well as from across the globe. That people with chronic health conditions, and I don't just mean mental health conditions, physical conditions, whether it's diabetes or asthma or what have you, they tended to miss routine or scheduled care. People were understandably afraid to go to hospitals, to go to clinics. Clinics weren't entertaining folks unless they had an acute condition. And so many people did miss their routine or their scheduled care. We know that these folks were also at higher risk for both contracting COVID as well as suffering complications of COVID. Unfortunately, those were the folks that were the most vulnerable, and fortunately were higher up in the priority for vaccinations when that started. We also know that people avoided hospitalization, especially last year in April and May when the pandemic was at its worst in New York City. We know that people didn't often adhere to their nutritional or other behavioral recommendations, whether that was diet or exercise, which again may have had an impact on their chronic conditions. This is a study that was actually done, result of what's called the Household Pulse Survey that is conducted by the US Census Bureau, and it shows that the average share of adults reporting anxiety disorders or depressive disorders compares the first 6 months of 2019 to 2021, which was sort of the midst of the second wave. And whereas the prior number was closer to 10%, it is closer to 40% when you look at the most recent survey. So that's a fourfold increase in depression and anxiety. So what's going to happen as we return to normal, and what should we expect and what should we hope to see? So I think that what's going to be important going forward is, and what we have learned is that widespread mental health screening is something that really ought to happen. In other words, it ought to happen in primary care health providers' offices. There was talk today about the pharmacy chain CVS planning to set up a cadre of social workers who would provide a brief mental health counseling in some of their healthcare clinics. We know they've started to do some primary care, and they may serve but that's an example of what we need: better screening. We know that certain groups are much more vulnerable. Minorities, healthcare workers. We've seen an immense rise in expectations for mental health care from our own employees, whether they are a registration clerk or a physician. And I think that's also been reported widely in the literature and the press as well. People who've lost their means of livelihood, people who've become unemployed, are obviously much more vulnerable. And I think, again, a widespread screening is essential at whatever point of contact they may have with the healthcare system or with the para-healthcare system. We know that the younger generation has been affected significantly as many of them have been unable to get to school. And yes, kids are certainly resilient, but at the same time, I think we need to have an increased focus on what's going on with them as we emerge into more normalcy than we have had. Addictions treatment, I think that's certainly something that we're seeing an increasing demand for. Again, it's been well written that people have been resorting more to drinking just to relieve stress. And certainly we've seen the folks with addictive disorders, even before the pandemic, not being able to access care. And I think that that's going to be something that we need to focus more efforts on. I think another one of the things that we will see when we return to normalcy is the persistence of telepsychiatry. Telepsychiatry, at least in the United States, was primarily reserved for rural areas where psychiatrists were far and few. Upstate New York would often be doing telepsychiatry with downstate New York. But now we're seeing that folks, and understandably folks from the Lower East Side see no reason to travel up to a provider at the Upper West Side when they can just as well do it over telepsychiatry. So I think that's here to stay. And certainly healthcare providers across the city and across the 5 boroughs have been adapting to it, including us at Mount Sinai. So I think everyone is sort of, now accustomed to it. And I think we've all accepted that it's here to stay. So what do we need? And this is my last slide. So there was some question about what do we need? I think we need increased capacity. Our mental health clinics are already bursting at the seams. And I think that we need to, somehow the community needs to increase capacity. I think assistance from the city, from the Office of Mental Health, be it the local office, the state office. I think those are agencies that will require sort of greater, to hear from advocacy groups across. I think we also need to prioritize surveillance. As I said, sort of the increased screening at every possible opportunity. And then research about short-term care, what works. And then lastly, I think what we've got to do for the long term, besides helping those that are affected now, is I think to try and think of ways to build resilience. We know that resilience can be increased in people. Resiliency methods can be taught. It's not just something you're born with. That does help, but it's a teachable skill. And I think that perhaps the focus in, even in mental health agencies, should be to sort of go out in the community to some extent, or to foster opportunities in the community to build partnerships where they can help folks build resilience or restore it where it's been broken down due to the sort of recurrent trauma. So I'm going to stop there and see if there are questions or things that I can cover that I didn't get to hear.
That was phenomenal. Anyone have questions? I have a couple, but I'll restrain myself. Courtney.
Yeah, that was great. Thank you so much. Couple of questions. I will try and keep. I have a lot, but I'll try and pick my top 2. Any kind of thinking about that telepsychiatry, are you seeing new people that you weren't seeing before coming into doors, or are you seeing greater usage and engagement among the kind of the similar groups, and they're just, the higher show rates? And then kind of the second part of that is, with the DNS in mind, are there things you would recommend us advocating for in order to build out our capacity on that front? And then I noticed, just on the last question, I'm so sorry, so many questions, but you said we needed greater capacity. Where, in which kind of, just a little more specificity on what kind of areas could capacity be increased that would be most helpful?
Okay, so let's see. I'll start with the last first. Where will increasing capacity be helpful? I think that is a responsibility that we all share as providers. So I think healthcare systems and hospitals may need to expand clinics. Primary care providers need to accept back into care patients that they've referred. One of the things that we often find in mental health, and this has nothing to do with the pandemic per se, is that once folks get referred to a mental health provider or a specialist, they tend to stay there even long after they need specialized care. So for example, if anyone here, or if any one of us has a heart problem, our primary care doctors might refer us to a cardiologist. The cardiologist might see us a couple of times, run some tests, start some sort of treatment. And in most likely cases, they will say, okay, this is the treatment. You've got to take it for the next year. Go back to your primary care doctor. They can monitor you. Maybe in a year, you can come back and see me. That typically tends not to happen in the mental health world. And that's because often primary care providers are reluctant to take back mental health patients for their mental health care. They'll take them back as primary care patients. So I think there's only a certain extent to which mental health clinics can expand. And I think what often happens is it's sort of a one-way, there's an indoor, but there isn't really an outdoor. And I think what we've got to work on with the primary care providers, and that responsibility rests with the healthcare system, is to try and say, treat us like any other specialist, send people in, we consult, we initiate treatment, we stabilize, and then we make recommendations for long-term care if needed. And then lastly, there are community health agencies that exist that may also need to expand. So freestanding mental health centers, the closest one that I can think of is, I think in the 130s, there's a Metropolitan Mental Health Center, Upper Manhattan Mental Health Center. These are freestanding mental health clinics. The other thing is that perhaps, and certainly the Sinai system is working on this, and I believe every health system is to try and integrate mental health care into primary care offices. So that when someone goes in to see their primary care doctor, yes, they can see a dietitian, yes, they can see a nutritionist, yes, they can see a gastroenterologist who's there one day a week. I think we want to make it such that there's also a mental health specialist. Doesn't have to be a psychiatrist, could be a social worker, a licensed mental health counselor, psychologist, who can see them in their primary care doctor's office, because we know that people don't want to and shouldn't have to travel from place to place. So that's the capacity question. Your first question was about who's accessing telepsychiatry. So the answer is both. We are certainly seeing greater utilization and greater adherence to treatment from people who were already peripherally established in care or perhaps not fully adherent. So that's one group of people. The second group of people, and then actually an example of that is kids. So adolescents sometimes wouldn't make it to their appointments because they didn't want to come, their parents couldn't bring them, they lived far away, their little sibling was sick, school let out late, they had some sort of hundreds of reasons why it was hard. And many of those reasons go away when the child can access their mental health provider from the safety of their own bedroom or their living room or whatever it is. So there's certainly that. We're also seeing new patients accessing care because I think the pandemic and the impact of the isolation, losses, has certainly led to more people accessing mental health care. And I think, to some extent, increasing education and destigmatization of mental health care has sort of brought more people in as well. And the question in the middle, can you remind me?
Sure. I think it was just, were there barriers to use? But you answered it. So
okay.
It was great, those specific groups. Thank you so much. That was incredibly helpful.
Richard has his hand up.
I think you referred to the departments of mental health in the state and in the city. Is to look to them for funding? Are we looking for them for funding for the programs?
So in some cases, the answer is yes. A little example of that is, so the mobile crisis team that I referenced is in part funded by the Office of Mental Health, but through a city, a grant. And interestingly, they've added responsibilities or expectations while reducing the budget, which then leaves the burden on the healthcare system. So that's a small example. I mean, that's not a big deal, but it's just an illustration of the point I was making.
Okay, that's helpful. The other question I had was, what was your experience of the department in terms of abuse issues, domestic abuse issues, especially during this whole period?
We did see patients coming in and reporting that they felt more threatened, particularly if there was a conflict at home with a spouse or a partner or whoever, that now that they were at home much more, that there was a greater risk. So we certainly heard that from some of our providers, from some of our patients. I think whatever situation at home existed got exacerbated in many situations because of the continuing isolation. And so yes, we did hear. The other thing is that there was more. I think people resorted more to drinking. Substance use went up, and those who were even in addictions treatment prior didn't sort of get to their treatment providers for a period of time. So I think those things may have contributed to this. And then the court system for a period of time last year was kind of closed down. And then it became telecourt. And so I think people's access to things like getting an order of protection became harder, just from a practical standpoint.
Okay. Thank you. In the interest of having our other presenter present, I want to thank you. You're welcome to remain with us, but I think you provided us with a wealth of experience and information and understandings that'll help inform what we do to support what you're doing, okay, and to understand what's needed in our community. We'll be focusing on our district needs and our budget priorities. So much appreciated.
Yeah,
Shelley,
thank you for the opportunity.
Shelley, would you mind if I ask the question?
Sure, go ahead. I didn't see your
Sorry.
hand. I'm sorry.
I'm curious about the degree of volunteerism
Robin.
in the profession. Many years ago, I was associated with an organization called Project for Psychiatric Outreach to the Homeless.
Yes.
Kathy Folks.
I volunteered with them myself, and
Okay.
I know Kathy quite well.
So you know
Yes.
what happened. I mean, they ran out of money, but it was, I think, an effective way of reaching mentally ill homeless people. I think they went to shelters. When necessary, they prescribed medication. And I think they did a fair amount of good. Is there anything like that in existence today, and can it be brought into existence?
The answer is yes, and yes and yes. So they were actually acquired by a corporation or some organization called Janian or something. I forget exactly.
Yeah.
Which then I think may have gotten subsumed under CUCS or one of the community agencies, but I could be wrong about the last bit. They were for a good length of time providing, again, free care through volunteers to some of the shelters. The other thing that's happened is, I think over time, I mean, I volunteered with PPOH, as it was called, over 25 years ago. I used to come up to Valley Lodge, which was on 106th Street, I think, and with Kathy. And I think what's happened is many shelters now have incorporated a little bit more social work, mental health support than they had before. So we have partnerships with shelters. For instance, I've met with several of the social workers that work in shelters nearby, and so we've built relationships with them. And I think there is room for more volunteerism. I fully agree with you. That was a great organization, and I think there's certainly room to do more.
Is it something that the city could provide seed money for?
Yeah, so they've got a program called Thrive, which you've probably heard about. And they are they've just started a fairly unique project. I think it started in conjunction with the Harlem Hospital, or somewhere, I think it's north of 110th Street, but will be connecting with us in some way. So what they're doing is they're having 911. They used to have a co-response team where an NYPD officer and the social worker went out jointly to a, quote, EDP call. What they're now doing is they're not sending out the police officer, they're sending out a social worker and an EMT instead, which I think is progress. And so that's starting up pretty soon. In fact, just today I was introduced to the person who is leading that effort. It's a pilot program, and because we know that the Morningside Emergency Room will see some of these folks, and so we want to build a partnership with them. So yes, I think there's much work to be done in that area.
Thank you.
Shelley, Robert,
Yes.
question for you. So Robert has his hand raised. So I want
I see it now. Thank you.
Okay. And then are we waiting for the end for the public to speak for their questions?
Are there anybody signed up?
Yes, there are several people.
Okay, we'll go. How many?
Rosa, how many do we have?
3 people.
3 people.
You know,
Okay.
the other thing I am happy to offer is, if even after I jump off this, if you have series of questions that you'd like me to answer, I think Brad can provide my email. As many questions as you have, please feel free to send them to me. Give me about 3 days and I will answer them. I will answer each
Well,
one of them.
Or
That is
to
very
make it a
kind.
little easier,
It's
to make it a
8
little
o'clock.
easier,
Can we hear
Dr.
the
Singh,
other
I'll
panelists?
take the questions and forward them to him if you want.
Can we
Okay,
hear the other panelists?
yes, so Robert is right. I lost Robert. Oh, there's
All right,
Robert.
I'm
Why
right.
don't you present your question and then we'll move on.
Okay, Dr.
And
Singh.
Walker.
Yes, thank you, Shelley. Dr. Singh, I can attest to the quality of the Mount Sinai Community Medicine Services. I was part of the origination board of Boriken. They were our medical partner when we began the centers in FQHC. And you had alluded to ambulatory mental health services. And I also did work with Chicane's Community Healthcare Association of New York State, where we supported legislation to add services to the FQHCs. One of them was mental health, ambulatory mental health services. What I'm wondering, if it's been a long time, what I'm wondering is with the centers that Mount Sinai supports, and I suppose you still support Boriken very strongly, it's a very thriving center, and the Ryan Center, and perhaps others, of the FQHCs I'm thinking of particularly, because that's the model. Do we have those services, whether Mount Sinai provided mental health services on an ambulatory basis at all, or still?
Do you mean, are we partnering with FQHCs to provide mental health services there?
Yes.
We aren't providing direct care in the FQHCs. I mean, the one that's closest, the FQHC that's most close to our sort of vicinity is the Ryan Centers, which is on 100th and then on 97th, I think, in Columbus.
Yes.
We've had partnership. We have a very close relationship with them. Their mental health capacity is limited, and so they tend to send many of their patients to us, and there are frequently times when we send our primary care to them. So we do certainly work very closely with them.
I see. Okay, very good. It's
Okay,
good to hear.
thank you.
It's good to hear.
Thank you.
Thank you.
Okay, we were at, Audrey and I were at a, Brad runs the Community Advisory Board for Manhattan, Mount Sinai West and Morningside. And we were very pleased to hear last night that there's a good, close working relationship between Mount Sinai and Ryan. The collaboration can only benefit the community. And
Yes,
we appreciate it. Okay, and thank you for your generosity and willingness to answer questions beyond today.
Yes, and if people need, I know that mental health services are a labyrinth. They are very hard to negotiate. And so at any point, if people need help negotiating or connecting with care or needing direction, even if it's outside the Mount Sinai system, I'm more than happy to serve as a resource. I can be easily accessed through Brad. Please feel free to reach out to me. I'll be happy to help anyone get connected or connect their friends or family to whatever they need, wherever it is.
Thank you for your generosity too. Thank you.
Bye.
Thank you, Brad. Okay. We have someone who's quite accomplished and a very different and a very clear focus of groups, mainly adolescents and young adults, and someone who is lives in our community, and we know from before, Dr. Amanda Fialk. She's the partner and chief of clinical services at the dorm. I think it'd be helpful if you explain what the dorm is first, which I thought you would. Sorry that we are so many minutes into the meeting, but we look forward to your presentation now. Thank you.
Thanks for having me. I'm also going to share my screen as well. And yeah, as Shelley said, I'm going to really focus in on adolescents and young adults, because that is the population that we primarily work with at the dorm, which is really an outpatient community integration program. And we see late stage adolescents and young adults who struggle with a variety of mental illnesses and addictions. And, you know, we see a pretty big range of clients, young adults who are living here on the Upper West Side, who grew up on the Upper West Side, went to our local public and private schools, and then also young people who are, you know, primarily getting treatment on full scholarships, who don't have necessarily access to the types of services that we provide, but we're able to scholarship or offer sliding scale fees. So it's a very diverse community. I think that the common denominator is that our young people are in pain emotionally and they're suffering. And what we know is that addiction and mental illness are not diseases that discriminate. They impact people whether they sleep on a park bench or whether they're living in an apartment on Park Avenue. They're sort of the great equalizer. I think the main difference is that marginalized populations don't tend to have access to the level of care that people who do have resources get to access. Before I get into the specifics with the young adult and the adolescent population, I just want to look at the impact of COVID generally speaking. And I know Dr. Singh spoke a lot about this, so I'll go through it quickly so that we're not redundant. But some of the things that we're seeing a lot of are certainly an increase in substance use. What we know is that up to 13% of Americans have responded that they reported that they were either increasing their substance use or started using more substances as a way of coping with stress or anxiety during this time. We're also seeing a 30% increase in overdose deaths, and this is largely due to opiate use. One of the things that our clients have said is that when we went totally virtual, we do a lot of groups that involve things like eating lunch together or eating dinners together. And when we couldn't do that in person, we were getting meals delivered to our clients' houses, and even, you know, restaurants in the neighborhood as a way to, I guess, I don't know, to get more business or to, you know, as a way to bond during this time. They would throw in a beer on the house, and our substance using clients who were ordering just a simple meal to eat during their therapeutic group were getting beers delivered to their house. Liquor stores were opened when other places of business, certain mental health clinics were not. So substance use is clearly been a target that we were trying to address and that we're still trying to address during this pandemic. The other thing that we're seeing a lot of is mood disorders, symptoms of anxiety and depression. 41% increase of people experiencing symptoms of anxiety and depression as a result of this pandemic. And then the last population that I really want to point out, because I don't feel that it gets spoken about enough, is people that struggle with eating disorders. In a survey that was done by the International Journal of Eating Disorders, it was found that 62% of people in the United States who were diagnosed with anorexia experienced a worsening of symptoms during the pandemic, and that hotline calls to NEDA increased almost up to 80%. You know, going to a grocery store during the best of times is anxiety provoking for somebody with an eating disorder. And when the pandemic hit and people were told to buy, you know, 2 weeks of food, and grocery stores were a very stressful environment, being in that environment and struggling with an eating disorder was a traumatic experience and was extraordinarily overwhelming. That, coupled with the fact that also when the pandemic hit, we were all seeing things on social media and on the news about gaining the COVID-19 and different memes about weight gain during COVID and specialized personal training programming. And it was a very, and still is a very difficult time for individuals who struggle with this diagnosis. When we think about mental illness, generally speaking, there's always this debate of nature versus nurture. Is a mental illness more biological in nature, or is it a result of the environment? And we know that it's a mix of both, but I think what the pandemic has showed us is that what is going on in our environments, in our outside spaces, has a profound impact on how we're feeling from a mental health perspective. With this specific pandemic, a lot of people that we treat were talking about the trauma that was involved in it and how this was a different type of trauma, different than even 9/11 or Hurricane Katrina, where there was a distinct event and then it was over and people could come together in, quote unquote, normal ways and grieve and hug each other and offer each other comfort. With this pandemic, we still don't know when the end will be. And we don't have the normal mechanisms for coming together and offering support and grieving with loved ones, with friends. And that makes this pandemic very, very traumatic for people. Also, the grief involved, loss of people, loss of identity, loss of financial security, loss of the ability to participate in important milestones, the isolation. What we say is that addiction and mental illness thrive in isolation, and that, for many, the opposite of sobriety or the opposite of the opposite of addiction or the opposite of mental illness isn't necessarily sobriety or mental health, it's connection. We need to feel connected to other beings to feel good, to feel mentally well, to feel mentally healthy. And we're missing out on those not only macro level connections, but also on the simple micro level connections, going to the local corner store and saying hi to the person who's working at the cash register, or passing by somebody on the street as you're walking your dog that you always see and having a quick conversation. Those micro level connections weren't even happening. And that leaves people who struggle with mental illness feeling very lonely in their illness. Also, the lack of structure and the increased screen time were contributing factors. Living in invalidating households and spaces. We saw this a lot with our LGBTQ plus clients, especially young adults who were supposed to be out of the home and in college environments and were now stuck at home and maybe did not have families who were validating of their gender identities, didn't use proper pronouns with them. That was contributing to their mental stress as well. And then cuts and limits to treatment services. As Dr. Singh said, there is a supply and demand issue right now, and mental health providers are doing their best, but there are more people that need help and that want help than are able to get help. And also, just not being able to get help in the ways that they are used to in those face-to-face contacts. So switching gears, I want to talk just a little bit about adolescents and young adults generally speaking, because even during the best of times, and I'm sure a lot of people on this call can, remember their own adolescence and young adulthood. And if you have children, you can certainly relate to this, but adolescence and young adulthood is a developmental roller coaster, even during the best of times. Young people are still developing physically and hormonally. Irritability and moodiness, stress, emotional lability are kind of the norm. And some of these milestones are pretty significant that they're seeking to accomplish, like establishing their identity, achieving autonomy, developing emotional stability, thinking about the careers that they want to launch into. If they're in high school, social acceptance, romantic issues, grades, parental pressure, peer pressure, getting into college. These are all such big tasks for young people to accomplish. And you throw a pandemic on top of this, and you almost have a perfect storm. And what we have seen as a result of this perfect storm is a significant rise in mental health and addiction issues for this specific age group. With school closures, with the loss of social connections, with missed milestones, this is a very triggering time. A couple of specific things that I want to point to for this age group that we have seen a lot of is first, stunted social and emotional learning. Social skills, emotional literacy, these are skills. And like any other skill, the more that you practice them, the better that you get. And if you don't use these muscles, they will atrophy over time. Things like self-awareness, self-management, social awareness, emotion regulation, decision-making, communication skills, skills that are really important for you to take with you for the rest of your life. For the past year, young people have not had the opportunity to practice them due to isolation, due to being in the home, due to not being at school. The other thing that we've lost is the first line of defense. Schools see our young people every single day, and not every young person is seeking out mental health treatment, even if they need it. And without schools seeing our young people on a daily basis, we don't have that first line of defense in recognizing things like learning deficits, signs of physical and sexual abuse, substance use, depression, and suicide ideation. The last thing too is, in terms of schools, that it's important for kids to get out of the home, and schools are an opportunity for growth and for developing identity, for developing a community outside of the family system. A lot of young people are very inspired by professors, by peers, and it offers them an opportunity to get a different perspective and to begin to develop a different type of ethical and value-based perspective. And again, this is something that they take with them for the rest of their lives. And spending time at home for the past year has taken them away from this opportunity for really important social growth and identity development. I mentioned this a little bit in previous slides, but I want to just come back to it. The whole family has experienced a lot of stress right now, and the whole system, for many young people, they're describing their family as feeling like it's going to implode. Parents are human beings too, and parents are feeling the stress of the pandemic. Parents are experiencing the trauma of the pandemic. They're juggling jobs and parenting and trying to take care of their own mental health. And that's often leading to just a tension in the home and ineffective communication and poor role modeling. And the tendency that we've seen a lot of our parents do is that in an attempt to want to protect their children from some of the negative emotions that they're experiencing and some of the grief and sadness, is that they're stepping in and they're almost over-parenting, trying to do too much of the schoolwork for them, managing their schedule, cleaning their rooms, being their alarm clock. And that is depriving young people of practicing and developing their own skills. So we're really trying to help parents to take a step back and take care of themselves and allow children to try to develop the skills on their own, even during this difficult time. For statistics, and again, I want to go through this quickly because anybody can Google statistics, but I think that there's some important things to look at. When we look at pre-COVID data about young people, and especially minorities, our LGBTQ population, and those with pre-existing mental illness, 30% of undergraduates live with some type of mental health disorder. 60% of incoming college students say that they wish that they had had more help with emotional preparation prior to going to college, that they didn't get this help in elementary school and middle school and high school. And many, many high school and college students are engaged in health risk behaviors such as alcohol use, drug use, bullying, risky sexual behavior, and that these behaviors are the leading contributors for death among persons aged 10 to 24. With COVID, we're only seeing these numbers go up. So for instance, almost 75% of individuals aged 18 to 24 were reporting that they were experiencing at least one negative adverse mental health consequence as a result of this pandemic. 13% of individuals who were surveyed were reporting that they had started or increased their substance use as a result of pandemic-related stress. And the groups that were most likely to do so, nearly a quarter, were ages 18 to 24. What we know is that in this young adult and late adolescent population, we are in the midst of a major issue when it comes to substance use. And again, this goes across demographics, across racial and ethnic identities. In the interest of time, I want to sort of skip down to the end because I know that you guys have been listening to a lot of panelists. I want to give some final thoughts just in terms one of sort of policy considerations, but the other just thoughts in general about how we're approaching mental wellness in the aftermath or as this pandemic is hopefully coming to a close. A lot of people are outwardly talking about how excited they are to go back to school and how they can't wait for the mask to come off and go to concerts and go to sports games. Not every young person feels this way. And for young people who struggle with mental illness, a lot of them are reporting to us that they are having a lot of reintegration anxiety, that they don't want to go to school in the fall, that they're not excited to resume normal life, that during the pandemic, for the first time in their lives, they felt understood because quote unquote normal people kind of felt the same way that they always feel. And that living in lockdown or living in isolation felt safe for them. And that they don't want to go back to doing things in person. And they don't want to see other people getting excited to go to outdoor restaurants or go to these concerts because they don't want to do those things. And I think it's really important to remember that for the young people that are struggling with mental health, especially as a caretaker, or as a parent, or as a community member, that it is normal to not be excited for things to go back to normal. And it's normal to be scared to reintegrate into life, whatever that new normal is, and that is okay. And we want to validate them versus telling them, oh no, don't feel that way. It's going to be great when you go back, and really have empathy for what they are going through. The other thing that I wanted to talk about is this concept of bottom, because I think it's a really dangerous concept, especially when we're looking at young adults and adolescents. You don't have to hit bottom before you ask for help. The elevator stops at many different floors before it gets to the basement. And if we can help young people to get off the elevator at the 6th floor, or the 7th floor, or the 5th floor, before it goes crashing down to the basement, their prognosis is significantly better. Asking for help and getting help is really hard. And a lot of times young people don't necessarily want to go to get help. They don't even need to want to get help for help to work. They just have to be willing to entertain the idea and go to that appointment. So again, as a community member, as a parent, as a caretaker, it is okay to not wait for things to get so bad before you help your child to get help, and to encourage them to get help and to get support before that elevator goes crashing down to the bottom floor. For policy considerations, I think we all know that New York City schools are slated to get a lot more money this year, which is a really wonderful thing. as a mental health professional, I always ask myself, what does it really mean to invest in our students and our children? I know that many, many people are excited about how this budget can be used about getting more art classes or sports programs or supplies for classrooms, and that, you know, doing these things would help students to stay in high school, to graduate from high school, to get into college. I also think it's really important that we look at ways in which the budget can be used to provide spaces as part of the regular and mandatory curriculum for students to do social and emotional literacy work. These, again, are skills that can be taught, that can be practiced. We need to be looking at this, especially now during the aftermath of a pandemic, when people are very vulnerable, when the mental health system is overburdened. I think schools can pick up a lot of the slack there and can do a lot of the prevention work and provide a lot of the spaces. And it can't just be something that, you know, students opt into. We don't want to just be opting into mental health. It just needs to be part of the regular curriculum so that there's not that sort of stigma attached to it. If everybody is participating in 2 or 3 classes a week that talk about emotion regulation skills and distress tolerance skills and interpersonal effectiveness, these skills go just as far in helping students to be successful in high school and college and thereafter as, you know, learning how to write a topic sentence or learning how to write a thesis. And the second that we can talk about mental health, generally speaking, and in schools in the same way that we talk about going to the dentist twice a year or getting a yearly mammogram, that stigma goes away a little bit more and it becomes just part of the day-to-day life of things that we do to take care of ourselves and things that we are learning in our educational spaces. In terms of the supply and demand issue, I think we need to get creative. And one of the panelists asked a question about peer support. I think that we need to get really creative with how we're using student interns, because they're such a valuable resource. I know during the pandemic, people who were in medical school were allowed to come out and practice and help out in hospitals. I think student interns, and we certainly have them at my organization, they are so helpful in terms of providing extra support and especially second and third year students, depending on the program that they're in. It's a positive for them in that they get practice working in the field, and it provides all of us with an extra set of hands. Also peer support specialists, peer recovery advocates. So people who don't necessarily have master's degrees or PhDs, but have had their own personal experiences in recovery from mental health or from addiction, I think are underutilized in our field and could be utilized a lot more, especially, again, now during a supply and demand situation. But generally speaking, I think we need to use them more. And I also think that we need to really be challenging insurance companies who love to take our premiums, but don't necessarily love to reimburse us for treatment. We want to, especially with young people, we want to avoid hospitalizations. We want to treat them on an outpatient basis. Going to a hospital, going to a residential treatment facility, being removed from your natural environment, that can be traumatizing. And as much as we can provide treatment in the community and create community opportunities for treatment, the better. But that often means that treatment at the outpatient level needs to be more intense. And insurance companies aren't always, they don't want to necessarily pay for that level of intensity on an outpatient basis. And because they don't, more people end up in that revolving door of hospitalizations over and over. Then last, and I promise I'll stop, is just, I think, creating more community clubhouses. Clubhouse models are amazing. Having safe spaces, non-stigmatized places, safe spaces that people can go to get their mental health needs in communities don't exist as much as they should. And there are some wonderful, wonderful models where people can get their mental health needs met. they can have safe spaces to go during the day to hang out, and that they can also be receiving vocational and educational services and support in these clubhouses as well. And if we can create more clubhouses and more areas within communities for people to feel safe going to get mental health treatment, we will also be keeping way more people out of hospitals and out of levels of care that aren't necessarily indicated and that probably could be stabilized on an outpatient level. And with that, I will end.
Okay. Amazing, phenomenal, another phenomenal presentation. We have time because unfortunately, our representative from the Ryan Center did not arrive. I've been in contact by email and text, and I don't know what happens, but it frees us up to have more questions. So Amanda, thank you so much. And I know that I thought I knew a lot. I learned a lot. And it's amazing the stuff you do at the dorm and how it really can teach us a lot about what might be done elsewhere too. So I see that Madge and Catherine and Robert. Madge. But you have to unmute yourself. Please unmute yourself.
Sorry.
Oh, yeah.
Thank you so much. That was such an excellent presentation. I learned so much. Are there any clubhouses in our neighborhood or connected with any other larger institutions like yours or Ryan's, or do these things have to sort of start anew?
Fountain House is a wonderful model. They're not directly in our neighborhood. They're more closer to Midtown. But I think that their model is fantastic. They do more of mixed age groups. So, one thing I would want to consider is having clubhouses. If I could have my wish list, I would love to have clubhouses that were specific for adolescents, some for young adults, and some for, and then for adults as well, just because, you'll hear an 18-year-old or a 16-year-old say, no offense to any of us, I don't want to hang out with, older people. I want to hang out with people my age. And they want to be surrounded by people their age that understand them and that are struggling with the same thing. But I think Fountain House is a great model.
Thank you. Catherine, please.
Robert can actually go ahead of me to make sure that this way he might ask the same question. I'll go after Robert if my question is new.
Okay, kind of you. Robert.
Thank you, Catherine. I think what we learned is that we really are all on the same page. But Dr. Flock, I think this is terrific as well. And you mentioned the clubhouses. And in my work back in the day, as we say, in community-based mental health services, the day treatment program was a required part of the treatment plan. And compliance was your entitlement to your apartment was based on compliance. And that was one of the items that you had to report daily to the day treatment center, which is a community center, exactly what you're describing. And what we should have done a long time ago, the pandemic is forcing us into. And when we grew up as children, only Shelley and I can remember this, maybe Madge, that we had, maybe not Madge, but we had community centers. And the community center was not just recreational, they had counselors, they had, if you had family issues, and they had lunch and that sort of thing. But in the mental health capacity, when you go to the day treatment center, the therapist there, and some of them, postgraduate center was considered, which I'm sure you're familiar with, I suppose they're still around. That was considered to be the Rolls Royce of, I'm talking the 90s and the early 2000s. That was the Rolls Royce of day treatment centers. And the residents would get up and pull themselves together and report to the day treatment center and spend the day. They might get jobs. They'll go for vocational training there. If they spoke no English, they might get ESL. And the therapist was there full time. And you socialize, and so it's an absolutely extraordinary community service that was targeted to a particular population. But what we see here is that it's needed, period, for all. So that's a very strong feature in your presentation, and I think it's something, Catherine and Shelley, that we should push for more of, and for funding for these centers to be created. And the key word is, I think you alluded to it, is normalization. So it's doesn't have to be anything wrong with you. Mm-hmm. You have to go there and become part of, integrated in the community in that way. And I will have later on, if there's time, I want to make an observation, because there's another experience I had that is very pertinent to today. So Catherine and Shelley, if there's time later, come back to me and I'll ask that question.
Okay. We'll try.
To piggyback on what you said, Robert, too, is, I think that especially for the younger age group, they're fun, right? Like,
yeah.
It's because getting help and asking for help and doing some of the inner work that is involved in recovering from an addiction or mental illness is so painful and so difficult and so overwhelming. And what young people need to do is they need to be able to also have fun with each other and know that there's other people their age that are doing that same hard work. And when their session with their therapist is over, they can go downstairs and play ping pong and get a release, and then go back upstairs to their group and start processing some more. But there has to be an element of connection and support and fun in this as well.
Yeah, absolutely.
Okay. Thank you. Catherine.
Yeah, so building off what Robert said, what do you think is needed to create more access to mental health services for children and youth and adolescents? Because you mentioned working with insurance companies, but there's so many kids that don't have insurance, and many providers also don't take insurance. So in terms of, and we've actually been working with groups in the city that address issues related to child sexual abuse. And one of the primary things that they talk about is that it can take months for them to get someone an appointment. And so can the funding that's going to the DOE, like, is some of that kind of set aside for mental health care, or what should the city be doing? What can we advocate for in terms of funding for people to have access to mental health services for free or for reduced costs? Because so many providers, there's not that many providers available that take insurance, and then there's so many people without insurance. So just wondering if you had additional ideas. And I love what you said about students, but in terms of specifics for funding.
Yeah, and that's, I think, one of the most frustrating things as a mental health provider is dealing with insurance companies, because you get on the phone with an insurance company, a person is on the other line that has never met your client, that doesn't know what's going on. You've been treating them for a year, and you say, my client needs to come in for X amount of hours a week of treatment, and they need these specific types of therapy. And the insurance company says, no, I don't think that that's true. I don't see the medical necessity. They need only A, B, and C, because they want to provide the least amount of services as possible, and you want to get them the most help as possible. And it's a really frustrating experience dealing with insurance companies. And I think that's why, people try not to work with insurance companies. So I think the question is really, I mean, it's a very large question. It's an overhaul of our entire insurance, the way America looks at medical and mental health care. There's no reason why everybody in our country shouldn't have access to both medical and mental health services that they need. And that is not the case right now at all. So I think it is a question of looking at funding and utilizing funding, both, and I'm talking more specifically for young people, like how do we really get young people the help that they need, getting that help in schools, because schools are on the front line. School is the one place where a young person is legally required to go on a daily basis, basically. So it is our best opportunity to really get eyes on them and to get them the help that they need by using some of that funding. And then I think what we were talking about before is using funding for these community mental health spaces where people have access to free and sliding scale fees, because insurance companies, they want to know, is this PHP, IOP, OP, or a hospital? They're not really so interested in the stuff in between, like the community integration programs or the clubhouses. They don't see the value in playing ping pong or all the people watching a movie together. I wish I had a better answer. I don't. I mean, I think that's like our biggest feat is dealing with insurance companies.
That's a fantastic answer. It's really helpful, and we'll reflect more and absolutely follow up. Thank you so much.
Okay. I think we can open to non-board members. Are there any questions from non-board members?
Yes. Rosa, do you want to read people's names for this?
Are you talking about the sign-up sheet?
Yeah. Do you want to read out people's names for the public to speak?
Sure. I think these were for the prior person, but I'll read them out anyway. Let's see. Carmen Quinones, I think she's gone.
They're just signed up for mental health. So hopefully, so we'll see if they're still here.
Yeah, Carmen Quinones is gone. She said she had to go. Daphne Ramirez. She's here. Nope, she's gone as well. And John June. Let's see. He's still here. Oops.
I just allowed John to talk. He'd like.
Yeah. Hello, can you hear me?
Yes.
My question was actually for Dr. Singh. So would you be able, I think he mentioned that he would make his email available for questions. Would you be able to share that out to the public? Because my question was more directed to him. So I'm not sure if asking it to the rest of the committee would be helpful right now.
Shelley, you're on mute.
I will provide Brad's email because he said that he would be willing to take the questions and then transmit them to Dr. Singh. Just one second. This is easy. If I can find it. I'll get back to you. Let's have another question. If you just hold on till next speaker, next person asks a question, I'll be glad to give you that information.
Sure.
There's no one else signed up on the list.
And no other? Okay, then I'll do it right now. I think I know it by heart, but I don't want to.
Kelly, why don't I do that and you keep running the meeting?
Okay. It's simple. It's bradcorn@mountsinai.org. The word Mount Sinai written out, MOUNTSINAI. So if there's no other questions, it's really an extraordinary presentation. We thank you so much for sharing and letting us know about the dorm. I'm sure there are people who have children and young adults and young adults who would need the service, and not everybody knows. People always say, where can I go? What can I do? Well, you're serving our community amongst others, so we really appreciate it. And I think it brings home that crucial population, adolescents and young adults, where so much goes wrong in their lives if mental health isn't taken care of during that time. All statistics show that. what I'd like to do is present a resolution which I put together during the presentation, except for the first paragraph, which I pre-wrote because I thought it was important. So I'll read it and I'll summarize some of the facts and then go to the resolve. So its mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make healthy choices. Mental health is important at every stage of life, from childhood and adolescence through adulthood. And that's a definition from the CDC, okay? Not my own. So I have a lot of statistics, but I'll read a few. Let's see, where do I begin? Okay, some of the things that we've learned at first, that telepsychiatry has been effective in the mental health field during the pandemic and probably will continue. That, let's see, that the people who were most effective were people with chronic conditions in terms of the effect of the pandemic on them, that family stresses were extremely difficult all around, but especially on adolescents and young adults. That there are areas that really were lacking in terms of capacity, including mental health screening, focus on the effects on healthcare workers and low-income groups, including those unemployed, having difficulty. Focus is needed on under 18-year-olds, which very often aren't attended to. Now, of course, the schools have been heavily funded for social workers, so we're hoping that that will do. But what programs are coming in are not clear. And I have like a dozen other facts. Among the young adults, especially minorities and LGBT, 60% of college students said they had they weren't emotionally prepared. And I believe you also said 30% of undergraduates, what was their situation? Do you remember, Amanda? The 30% of undergraduates
Have some type of, are experiencing a mental health symptom at any given.
Mental health symptom. Okay, so those facts and a lot of good stuff that I gleaned from it. But these are the things that I think we could put in the resolve of things that we could advocate for. First, to call upon mental health care providers to provide expanded capacity of their clinics and services. Have the New York City and State Department of Mental Health provide the funds for expansion of services, including mobile crisis teams. New York City and State Departments of Health to increase funds for mental health screening, and for and hopefully to build more free-standing mental health clinics, which we do not have in our community right now. Call upon the mayor and the chancellor to create spaces to process feelings, emotions, grief, and trauma at elementary, middle school, and high school. Social and emotional learning as a part of the day-to-day curriculum, which was probably a good idea to begin with. and mental health providers to create more community. We talked about community clubs, clubhouses, and to get creative with using student interns and peer, what are they called? Peer recovery advocates, okay, that are in the schools. And in terms of the insurance, I think it means going to our elected officials to deal with the insurance issues, especially for adolescents and young adults, so that they can be outpatients and not have to wait till they need to be hospitalized. So that, in essence, is the resolution. Open to any additions. We can always take a look at it in writing and make a couple of modifications if necessary. Is that okay with the committee? Okay, does anyone want to move the resolution?
Can I
Go
actually
ahead.
just ask one question, Kelly?
Sure.
Of Amanda. Esty Williams is here, and she asked a question about inpatient psychiatric units and beds. And it made me think of course, you want to provide outpatient services, but
We're unable to hear you after you said outpatient services.
Catherine, you're muted.
I think what she's asking, if I can read her mind by now, is that aren't the inpatient sometimes really necessary and preferable for some people?
for those districts. Yeah.
Because of the intensity of their mental health issues.
Right.
Catherine, we didn't get your full question. I don't know if you can hear us, or we're guessing what the end of it was.
Can you hear me now?
Now we can, yeah.
Okay, I'm so sorry. My internet's not the best. So what I asked about was if there's more needed for inpatient services for youth, and also if there's anything in particular that's needed for District 75 or District 79 students. Because District 79 serves students with severe disabilities, and District 79 serves students that are in addiction programs and that kind of thing.
Yeah. So, yeah, I mean, of course, for certain, if somebody is a danger to themselves or others, of course, they need to be, in a hospital setting, and that's what we do. We get them into inpatient beds. That said, mental illness is not that much different from physical illness in terms of how we approach treating it. You don't want to take 500 milligrams of an antibiotic if 200 milligrams is going to help make you feel better. You want to try to help a person feel better with the least intrusive means as is possible, especially knowing what we know now. Everybody has experienced during COVID what it's like to be taken away from your community and your support network. And when you go away to a hospital setting or an inpatient setting, you are removed from that. And that's hard, that's difficult. And then you have to go back anyway. So after you're done with that, you still have to learn how to live life on life's terms, so to speak. That said, during the pandemic especially, there was no doubt a shortage of inpatient beds, and people were wanting to get away to go to treatment and be in a safe, contained environment, especially being safe from COVID too. And they weren't able to access the beds that they needed to access. And beds are always going to be an issue, but it's not only beds, it's also length of stay, because you can get somebody into a hospital, but if the hospital will only keep them for 24 hours, what is that really doing anyway?
So can we add that, Shelley, both something, and we can work through the language, but something related to patient services, and maybe, I don't know if I heard this, but maybe trauma-informed care as well.
Okay. We will work it out. That sounds good.
We'll work it out.
Okay. Does someone want to move the resolution as best as you can understand it? I can't make my own motion. Just raise your hand if you want to. Okay. Okay, seconded. All in favor? Okay. No, I see all in favor. So good. Unanimous.
Non-committee, you can put me in.
Non-committee? Uno, dos. Okay, terrific. Now, thank you so much. Please stay if you'd like. It's been a long evening. The last part will be, and the committee has received copies of this. I think it's incumbent upon us to respond to the Asian hate situation, which is spiraling. And I put together some of the facts and then some suggestions, and I got a couple of some feedback, but if you want to add or subtract or edit or do anything, you are welcome. I'm going to read it. This resolution is based on the following information and facts. There have been a significant, troubling increase in the anti-Asian hate crimes and bias incidents in New York City. In 2019, there was one reported incident. In 2020, 30. 16 of the 30 were violent crimes. Between February and December of 2019, 30 bias incidents of anti-Asian discrimination and harassment were reported to the New York City Commission on Human Rights. During the same 11th month period in 2020, the number increased to 205. According to New York Police Department statistics, hate crimes against Asian Americans skyrocketed last month, with 31 hate crimes reported in March 2021 alone, and none logged in the same month in 2020. So March 2020, there were none. And here we had 31 in 1 month, whereas last year, 30 in a whole year. Since the start, and these are the reported ones. Since the start of COVID-19, we have seen a sharp increase in instances of hostility and harassment directed at Chinese and other Asian communities related to COVID-19 stigma and misinformation. The New York City Commission on Human Rights, the Mayor's Office for the Prevention of Hate Crimes, the Mayor's Community Affairs Unit, and the Mayor's Office of Immigrant Affairs are coordinating closely to educate the public about their rights and protections in light of COVID-19 related stigma and hate crimes. It is crucial to note that the hate crimes and bias incidents have been found to be vastly underreported, so the numbers only reflect reported incidents. The United States Senate, in an overwhelming bipartisan vote, sent Congress's strongest message yet, condemning anti-Asian hate crimes by passing a bill aimed at improving data collection 94-1. These are the resolves. Therefore, be it resolved that Community Board 7 calls upon Mayor Bill de Blasio to immediately appoint a task force to manage complaints of violence against Asians and Asian Americans. Be it further resolved that Community Board 7 calls on the Manhattan District Attorney's Office to work with the task force to coordinate best practices that will maximize successful arrests and prosecutions. Be it further resolved that Community Board 7 calls upon Mayor Bill de Blasio to act to guarantee that mental health and social services be identified and introduced to all victims of violence so that their trauma from the violence, as well as the legal processes, are minimized and dealt with as needed in a culturally sensitive way. Be it further resolved that Community Board 7 calls upon Mayor Bill de Blasio and Schools Chancellor Misha Ross Porter to implement policies that ensure inclusion of Asian American history and culture in the curriculum of all grades in public schools. And be it furthermore resolved, the community board 7 urges Mayor de Blasio and the Chancellor Misha Ross Porter to formally recognize and to implement actions to celebrate Asian American and Pacific Islander Heritage Month in all New York City public schools. Okay. Any movement to, yes, Rosa? You want to
Sure. Yes.
support? Is there a second? A
I also-
second? Okay, a second. All in favor?
I have, wait,
Yes,
I
go ahead.
just have a comment.
Sure.
I just want to make sure that, I just want to throw this out there, something I want to just work on in the next 24 hours. What I'd like to do is just reach out to our contact at the DA's office to just get their, to see if they have any thoughts on our resolves, since we've been in regular in touch with them about this. And then there's also been some other resolutions that have come out of other community boards in Manhattan. And I've seen a couple of them, so I just want to give those a skim to see if there's anything small that we want to add. So I can do that work like next day and then share it with the committee if there's any minor change.
Sure.
But otherwise, I completely support it. It's awesome. Thank you so much for doing it.
Okay, I consulted with people in the Asian community and Korean community, and with two of the boards about were they doing anything and what were they advocating for. And the task force idea was something that they approved of and thought would be effective. That there can't just be the normal thing. We have an extraordinary situation. But we can always modify it. We have a week. Madge.
Could somebody just take account this time, because I see people have left, and on the last question, we never took account of anything.
Last one was 6 to 0 to 0 to 0 and 2 to 0 to 0 to 0.
Thank you.
Okay, thank you. Appreciate it. Okay, so all in favor? Aye, 6, okay. No, okay, and board non-committee members. 2, okay. Polly, you still there? Okay. Cindy, hi, Cindy.
There are more than 2 community members.
Hi.
How you doing? Okay.
I'm good. How are you?
Good. Good to see you. Front and center. Okay. We don't have anything else on the agenda. The important thing looking forward is 2 things. The environmental justice group, we have strongly represented by Rosa and Polly. And Sarah's involved with it now too, right? And am I missing anybody? And Madge is involved. So we're very strong. We're environmentally just as strong. That we should be conscious in all that we do, that that's not just a project. That's something we should be looking at whenever we're considering issues. And so we keep it in mind and always ask those questions. Because the presentation last night, I couldn't stay for the whole thing. I thought it was over the top, and given, and the most important thing, and I got feedback from Carmen Quinones, the pictures. She's been talking about these issues for years, but when you see the pictures, it makes sense. Okay, since we're dealing with Asian thing, it was a Chinese proverb that a picture's worth 1,000 or 10,000 words. That's so true here. Okay, so we should keep it in mind and not just put it aside as a project done. It should pervade all issues that come up as appropriate. We need to focus on our DNS, the district needs statement, and budget priorities looking forward. So I'm going to try to get our previous ones, which were so well done. Thank you, Catherine, and everybody else. That it would be a great source of basis for thinking. Of course, what Roberta said was so true. In light of COVID, there could be many changes, but I believe a lot of what we did would be applicable still now, and things haven't gotten that much better given what we've been through in the past year. But the budget priorities might add things or modify them. So within a week or so, you should expect those documents to look at. So one thing we'll do at our next meeting is do what we were supposed to do on that list for the next meeting. Catherine, any thoughts? Last thoughts?
I want to thank everyone for their contributions to this meeting. So many people support making these meetings possible and run smoothly. So I want to thank Rosa for being our amazing tech lead. Thank you so much. And Doug and Mark for helping. We really appreciate you. I want to thank Shelley also for writing 2 fantastic, strong resolutions and for organizing this fantastic meeting. And I hope everybody has a wonderful evening.
And Madge,
And
originally
congrats again to Shelley.
What's that?
And congratulations again to Shelley.
Oh, I'm already clapping. Thank you.
Before we go, there was a person that signed up, Annie Mangees. I just want to make sure, I know everybody's gone, that she's acknowledged because she had a question. I don't know that anybody can answer it at this point, but we did receive your question.
Okay. Well, if we could get a copy of the questions, I could send them off to Brad.
Okay.
And then they'll get direct responses, maybe.
See, Annie is still here.
Is she still here? Well, maybe she wants to ask the question. Maybe our collective wisdom, or maybe we won't have any. Annie?
Yes, hello?
Sure, please.
Hi, everyone. Thank you for this presentation. No, on Sunday, I was at Verde Square. I walked the whole neighborhood all the time. And I actually started crying. And it was mental health on full display. There was a man with his pants down on the ground. He looked dead. And an ambulance came. There were many elderly people with shopping carts. And it takes a lot for me to get choked up, but we need this is emergency. This is the mental health problem across the city is no different than COVID, and we have urgent care. Why can't we have mental health urgent cares? And I guess what could be done, at least in high visibility spots such as Verde Square. I saw people in hospital gowns. What more can we advocate for? What more can be done that we all can do? That we all can do. We can't save everybody, but what can we do more as a community board, as community members? SOS, I guess, it's the.
Your point is well taken. One of the things that really hit me tonight was with the mobile crisis team, that a lot of stuff is not happening behind closed doors. Okay, people are suffering and they're in the street and they're moving around and they need help. And we don't have resources on the street. Even the Manhattan Outreach group that's run over by Goddard comes around and sees people if they're living on the street and tries talking to them and working with them. but not everybody's living on the street. People are walking around.
Yes,
in the
there's many,
street.
yes, there's many walking around, but they do have a home, but it's,
Right, but they're having difficulties and they're,
absolutely.
you know, and so there's a gap there. What do you do to support those people? And something we have to look into and talk more about. But thank you for raising it because it's real.
It's real, it's
And
absolutely
it's in
real.
our community.
Absolutely.
Thank you, Annie.
Thank you, everyone.
What's her
Okay.
name?
Annie Mandes, Mandese.
Thank you.
Okay, and thank you, Madge, for taking minutes. Because our minutes go for hours.
I would say pages.
Okay,
The live transcripts can help. The transcripts with the videos that are posted on YouTube, those can be helpful.
okay. So on that somewhat sober note, everyone stay well. Our next committee meeting is on May 25th. Correct? Yeah. Okay, but we'll be in touch before, one with the budget priority and that information, and two, with the final versions of final version of a mental health resolution. And there's so many things we have to do. I think one thing about the role of this committee is like we're in the middle of everything now, right? It seems that everything that people are concerned about touches on our committee. So what we do, I think, is meaningful. I think people appreciate it and it's necessary. So let's be in touch. Okay. Have a good night.
Bye.
Thank you, Doug. Thank you, Mark, especially for giving us the time and and you're the host with the most. Thank you.
That's Rosa now. I've been relieved, so I'm a lucky guy.
Mm-hmm.
Rosa is the host.
Was the
Rosa's
hostess
the
with the
host.
mostest, but
Mostest.
I didn't want to be gender specific because
Shelley, congratulations again. You are the mensch of all mensches. I think that was.
thank you for the honorable mention.
Did we do the motion to adjourn?
Motion to adjourn. Have a good night. Thank you. Okay, thank you.